Next speaker is Dr. Smita Narayan. Madam is a professor at Thrissur Medical College and she has more than 20 years of teaching experience. Madam's topic is on complications of trabeculectomy.
Good morning, ladies. Good afternoon, ladies and gentlemen. I shall be speaking about some of the complications of trabeculectomy. Basically, a filtration surgery is a trade-off between efficacy and safety. So the more your surgery is able to control the intraocular pressure, the less likely is that it would be safe. That is, the chances of having a complication are higher, and that is why even perfect trabs create ongoing worries. You still have worries even if your intraocular pressure is controlled for, say, more than a year. You still are worried whether there would be an adverse effect later on or not. So today I'm going to describe these complications into three groups. The first is the most dreaded complications, which not only you as an ophthalmic surgeon would find it difficult to manage, you will need the services of a vitreoretinal surgeon. And secondly, even after getting the services of vitreoretinal surgeon, the prognosis would not be great. The second group is those which are slightly less dreaded, but you will not need the services of a vitreoretinal surgeon. You as an ophthalmic surgeon are most likely able to manage that, but again the prognosis in most of them is not great. And then the third group is the irritating complications, where the patient is always going to be behind you, but those are things which can be managed. So let us look at this patient. This was a patient who came after a small incision cataract surgery with severe pain and blurred vision. On examination, there was, not in this picture, but there was a uniformly shallow anterior chamber with an intraocular pressure in the late 20s. This patient had a patent iridectomy, and when a UBM is performed in such a patient, you can see iridocorneal touch. Most of the times, the risk factors are a preoperative high intraocular pressure, sudden shallowing of the anterior chamber intraoperatively, or history of aqueous misdirection syndrome in the other eye. This patient was medically managed with cycloplegics and topical steroids and aqueous suppressants along with intravenous mannitol. You can also perform an argon laser shrinkage of the ciliary process through the large iridectomy, or most importantly, you can do an anterior hyaloidotomy if the patient is pseudophakic or aphakic. But the most definitive management is to make the eye unicameral, meaning that the anterior chamber and the posterior chamber become one. So that is by doing an iridozonulohyaloidovitrectomy, wherein you can see this video with the patient with a flat anterior chamber, and here first a vitrectomy port is done. First, a vitrectomy port is made and a small vitrectomy is performed so that the anterior chamber is deepened. After that, when the anterior chamber has deepened, you can perform your phacoemulsification and implant the intraocular lens. Then again you go back to your vitrectomy port and then perform a small core vitrectomy and direct your vitrectomy port anteriorly to perform a hyaloidotomy. You can use iris hooks to visualize the periphery of the lens capsule and perform an anterior and posterior opening on the anterior capsule, and then come again into the anterior chamber and perform a iridectomy. So now you have a continuous communication between the anterior and posterior chamber, and in this patient the intraocular pressure was managed. The second instance is of a patient who was 78 years old, who had a trabeculectomy done 2 weeks back and came with sudden excruciating pain in the eye with sudden loss of vision. And on examination, the eye was shallow with stony hard and was stony hard. So usually such patients present into the casualty after some amount of straining or a sort of Valsalva maneuver, like say they are going and straining in the toilet or sneezing or coughing, or they are trying to reach for something and then they're holding their breath. So on the B scan, you can see this heterogeneous echoes, which are indicative of the presence of blood in the vitreous cavity. Intraoperatively, it can be identified as a change in the red reflex. You can see a shadow moving across the pupil, and then the iris and the vitreous try to come out of all the incisions that you have made. Eye is stony hard with a shallow anterior chamber. So this usually happens when there is a sudden decompression or hypotony during surgery in elderly patients with uncontrolled systemic hypertension. So this has to be managed by a vitreoretinal surgeon. Usually you have to perform serial ultrasounds to look for clot lysis, and at that time the patient will have severe pain in the eye, so you have to give opioid analgesics to manage that pain. So after adequate clot lysis has occurred, you can plan a surgical removal of that straw-colored fluid, and that can be done by doing an ultrasound B-scan to find out the highest area of elevation where you can do a sclerotomy. And then most importantly, you have to keep an anterior chamber maintainer, otherwise this is a vicious cycle which can keep on recurring. So once that anterior chamber maintainer is there, you have to press with the bud to milk out all the straw-colored fluid. A wipeout phenomena, nowadays we do not usually say wipeout phenomena because we know most of the causes which can lead to wipeout, but it is the sudden idiopathic, irreversible loss of central vision seen in people with split fixation or severe hypotony. You can see the split fixation here. And the last condition which is very terrifying is the blebitis or other manifestations leading to anterior chamber inflammation or endophthalmitis. So you have this typical white on red sign in the eye, in the bleb area, and when you do a B scan you will see low to moderate echos which are like clumps which tell you about the and in this case you can also see that there is a very shallow retinal detachment. Mostly it is associated with mitomycin C used for a longer duration of time. And now it has been said that instead of mitomycin C, chronic blepharitis is the most important risk factor. It may also be associated with bleb leaks which have not been attended to. So for every trabeculectomy patient, you have to give us specific advice to avoid splashing water into the eyes and use a protective shield during sleep, or use protective goggles or avoid swimming. Should not use antibiotic eye drops for a long time, and steroid drops, though they have to be used, they should be under the supervision of the ophthalmologist. And most importantly, you should warn about early signs of blebitis and endophthalmitis. Now there are other complications. Bleb leak has already been discussed. You can see this robust bleb leak which happened after a few days on the first or second post-op day. So the most important thing about bleb leaks is you should prevent it on the table itself. You should not let a bleb leak happen. Though it happens, but it is best to prevent it on the table itself. So you can apply a purse string, you can do a patching or a conjunctival aqueous suppressants. The large bandage contact lens, the 16 mm bandage contact lens are a great idea. In the late stages after trabeculectomy, you can have a sweating bleb, and I have found that autologous blood is a good idea. In the management, you can inject blood and that can cause some fibrosis. Free conjunctival graft can also be done. It is important that we suture the bleb with the two wing sutures at the edges, but sometimes if the conjunctiva is loose in between, you may have to put in a suture in between so that the bleb does not retract. Choroidal detachments happen with most of the trabeculectomy. When you are giving these topical antibiotics, most of the times that is managed well, but sometimes the choroidal detachment can lead to hypotony. So again, you may have to give systemic steroids. What is important is that you should prevent this kissing choroidal formation, because that means the patient will lose vision. You can anticipate that the patient may have choroidal effusions in patients with nanophthalmos, where you can make a sclerotomy preoperatively, which is very helpful in the management. The next instance is about hypotenuse maculopathy. So basically this is more a problem with the sclera, where the sclera has either melted or the sutures have given way. So you can use the adjacent sclera, where this is a video where we have used the dissected partial thickness adjacent sclera and then turned it over and then sutured it over the bleb. You can also, this can cause hypotenuse maculopathy, and if the folds become permanent, then the vision loss can happen. It is very difficult to calculate the intraocular lens power in a patient with hypotenuse maculopathy. Then in the case of an overfiltering bleb, you can place the Palmberg sutures, which are sutures from the conjunctival end of the bleb, placed much more posteriorly into the sclera. These are 9-0 or 10-0 nylon sutures, which are placed tight. And as weeks progress, the sutures get buried into the bleb and the bleb gets localized. And so you don't have to actually take out the sutures. And so there is a sort of reversal of hypotony with this. Bleb failure actually is a very big topic. I'm not going to discuss everything about it. The subconjunctival or episcleral fibrosis has an incidence of about 20% in the early post-op period and 30 to 50% in the late post-op period. You may have to consider the management depending upon the stages of the healing of the bleb. Like in the inflammation, in the early inflammatory stage, you may have to increase the number of topical number of times you're putting topical steroids. In the proliferative phase, you may have to go for suture lysis or a digital massage. And in the late stages, you may have to go for needling or even a bleb revision. Among the lesser complications is the bleb dysesthesia, and this is a video given to me by Dr. John Davis Akra. You can see a small bubble coming out every time the patient blinks, and that is a very irritating complication for the patient. You can see this bubble at the edge of the lid. So such a thing can be associated, this dysesthesia can be associated with a click, an audible click, which the patient finds it very irritating. This can also be associated with a Delin, where there is no wetting of the cornea adjacent to the bleb. Then you can have this overhanging bleb, which is like you are using mitomycin in 4 different patients, and all the 4 will have 4 different kinds of bleb. And this overhanging bleb, it's cosmetically not very great to look at. You can just dissect the bleb from the surface of the cornea using a visco cannula and then cut it off. Most of the time it works very well. Maybe you may have to use a suture. I have tried to describe many of the complications. Still there are many. These are my references. Thanks to Dr. Jayaprasad, Dr. Sunita Dubey, thank you, and John. Thank you very much for your kind attention.
Thank you, Smita madam, for that very useful